About breast carcinoma. This is the part third of the video. Now in the previous videos we discussed about the introduction part, the risk factors of the breast carcinoma, the morphological types, the molecular subtypes. In this video we will discuss only about the prognostic and the predictive factors. So it is going to be a very short video in which we will discuss only the factors which are responsible for the prognosis of the person and for the therapy of the person. So firstly, invasive versus carcinoma in situ. So as you can guess that carcinoma in situ, the patients who will be having carcinoma in situ, they will be having better or excellent prognosis. That means their disease will be cured if the person have in situ carcinoma and gets the treatment, the cure has been done. So it will be as normal as a normal person. So it has very excellent prognosis. Invasive carcinoma, there are further factors. If the person presents with distant metastasis, as you can guess, it has a very bad prognosis. However, the palliative therapy and other things can be done. Then lymph node status. Now this is one and single most very important factor which is responsible for the prognosis of the person. In that also axillary lymph nodes are very important. So axillary lymph nodes, mostly when they do mastectomy, along with that axillary lymph node dissection is also done. Okay, so axillary lymph node dissection is also done so as to remove axillary nodes, so that there is no further distant spread. So there is something known as sentinel lymph node. Sentinel lymph node is the first lymph node which is draining from the lymphatic vessels from the breast, from any organ, in this case breast. So that is the sentinel lymph node. So if we take out the sentinel lymph node, or we take a biopsy of sentinel lymph node and it is free, that means it more chances are there that there is no lymph node spread. So axillary lymph node dissection can be avoided also, but mostly the surgeons go for mastectomy along with axillary lymph node dissection so as to be safe, because this is the single most important factor. Then tumor size. Tumor size along with axillary lymph node dissection, lymph node status is important. They are independent of each other. However, if the tumor size is more, there is more chances that axillary lymph nodes comes to be positive also. Then locally advanced disease. If there is local invasion, such as the patient can present with ulceration of the skin over the breast, skeletal muscle involvement is there, so this has little bit bad prognosis. Then inflammatory carcinoma. Inflammatory carcinoma also has a very poor prognosis. This type of carcinoma, mostly the patient, as the name suggests, inflammatory. The patient, when they present, they will present with breast erythema. The breast will be very red in color, will be very engorged, will have appearance will be pewdy orange appearance because of the involvement of the Cooper ligament. Okay, the Cooper ligaments are involved, therefore it gives a very pewdy orange type of appearance, like a orange peel appearance is there. There is a skin thickening. So such if presentation is there of the person and it comes to be positive, it's mostly very high grade carcinoma, and it mostly patients present with distant metastasis, so has a very poor prognosis. Then lymphovascular invasion. So whenever we make a slide of the breast carcinoma, there are you can see vessels inside the tumor, you can see the lymphatics inside the tumor. Okay, so if these are involved, the lymphovascular invasion is there, that means the tumor cells are present inside the vessels, the tumor cells are present inside the lymphatic vessels, so this has a poor prognosis. Then molecular subtype. This also molecular subtyping is done on the basis of ER and HER2, so on the basis of proliferation. So according to this also the prognosis will change. You will understand individually also, I will tell you. Then histological subtypes. Now there are some histological or morphological subtypes which have a better prognosis and some which have a bad prognosis. So subtypes such as tubular, mucinous, lobular, they have a better prognosis. However, tumors such as metaplastic carcinoma has a poor prognosis. Then going to the histological grading. So the grading system we discussed in the previous video, that was Bloom-Richardson grading. So higher the grade, bad the prognosis. So if the tumor is poorly differentiated, it has a bad prognosis. Then proliferative rate. Proliferative rate, if the proliferation, if we see of a carcinoma, we can do by two methods. They can be mitotic count on the light microscope itself, or by IHC with the help of Ki67. So if the proliferation is high, so it will have a bad prognosis. Then ER and PR, these hormonal receptors are very important, because these receptors are important as they will be taking the patient for the therapy. If the patient wants has to go for hormonal therapy, if ER and PR will be positive, then only the patient will can go for the therapy. So ER and PR also, if they are positive, gets a better response, because they can respond to the hormonal therapy also. Then HER2 overexpression is mostly related to very high grade carcinomas. They have a poor prognosis, but one thing is good, that nowadays the specific targeted therapy to the Herceptin receptor is there, trastuzumab you have for that, and therefore the prognosis is a little better. Then P53, if there is mutation is there, this leads to most of the tumor have very aggressive behavior in this. Now going to the staging part. So that the two things are there. One is grading, which we discussed, and then the staging also. Now in staging, it is on the AGCC staging. So there are 4 stages. As you can see, the 4th stage will be bad and the earlier stage will be good. So stage 0 is nothing, it is just carcinoma in situ. Then stage 1. Stage 1, in this you have to remember the tumor size is less than 2 centimeters. Okay, there are no metastasis, no distant metastasis. Okay, so you have T stands for your tumor size. You have your N, that is the lymph nodes. Your M, that stands for the distant metastasis. Then stage 2. Stage 2, here the tumor size will be more than 2 centimeter, or but less than 5 centimeter. Okay, it will be more than 2 centimeter but less than 5 centimeter, and lymph nodes can be involved are 1 to 3 lymph nodes, but the distant metastasis will not be there. Then stage 3, here the tumor size, if it is more than 5 centimeter, automatically it goes to stage 3. How much lymph nodes are present, are positive or negative. Size should be more than 5 centimeter. If it is any size, okay, less than 5 also, but the lymph nodes 4 are involved, then also it goes into stage 3. Or invasive carcinoma, in which you see involvement directly of the skin, of the chest wall, or inflammatory carcinoma, so it will go into stage 3. Then lastly is your stage 4, in which the distant metastasis is present. If distant metastasis is present, it automatically goes into stage 4. So according to the stage also, the prognosis of the person will vary. So this was all about, this was a very short video. It was all about the prognosis of in the breast carcinoma. If you like this type of videos, do like, share and subscribe. It will mean a lot. Thanks for watching this video. Thank you.